So I just want to briefly thank everybody in the audience. I know everybody's been really patient today. I know you've received a ton of information and discussion about the various facets of this problem. It's a very complex problem, and so this is really an opportunity for you all to ask questions of our panelists who are here today. So I have one over here.
Thank you. I'm just interested to know if you all are aware of any research out there or anything that addresses why this issue is such a big problem in the United States versus in other countries across the globe.
So I do comparative health policy too, because I have to. So there's a book called Governing Addiction, and it is a typology of all drug policy systems across the world, and they talk about why and my next paper is on this topic too. So why do we have a big problem? Because our drug policy system by standards are considered draconian. We're still doing what other countries were doing in, maybe we're up to 1985 now with CARA, but we're very behind. We're very behind.
So I would just add to that, however, that literally in the last few weeks, a number of studies have come out showing that the problem is actually rising in other countries as well. It's just that we were the first. And so as we get in...
It's not the same level, though.
Not yet, but the increases seem to be coming into serious concern, and the hope is that people will learn from what we've seen in the United States and stop it, at the head here. But it's certainly, while it is far worse in the United States, we are seeing in some other countries the same issues. There's also some evidence that pharmaceutical companies being restricted more in the United States are targeting other parts of the world for their sales of their drugs that are being, because of all the information that's come out in the U.S., are being more restricted.
Definitely check out that book, though, because it's by Oxford Press. It's called Governing Addiction, and it's by the leading drug policy scholars in the world. And it goes over all the typologies.
Yes, and thank you so much for coming. If anything, today has shown me just how much misinformation I've been fed over the years. So building on the question that was just asked, do you all have recommendations of books or authors that we can look at leaving this symposium for further research on these issues?
So I don't want to. My dissertation's on this topic. I had to build my coursework. When I started doing this, there were no books published in it. I started it before we decided we had an opioid epidemic, and I had to go rebuild them. So the famous works are by David Courtwright. Those are the big policy historians. I don't know about treatments and efficacy. You guys can talk about that, but those are the must-reads for any drug policy student.
If you want a good read that will really kind of give you the history in the United States, get Dreamland by Sam Quinones, who's it's not like a scientific book so much, but it sort of will tell you some of the story and give you some perspective.
I come from Ohio. I would not. I would. It's a narrative.
It is what it is.
It's a narrative.
He's a journalist. It's not a scientific book, but in terms of helping people sort of understand the human side of some of this, it has some good stories to it.
The other thing, too, I think this symposium issue is actually going to have a lot, right? I mean, because, I think most of us are submitting papers that are probably going to be heavily footnoted. And, so Maria's got the website, what is it, Helping Others Live Sober. That's got a lot of resources. So, I mean, that's sort of an upcoming resource that's going to have, I think, a lot of other sites in it, right, to other papers, other books, and that sort of thing.
And going off that, there is a Memphis Law Review Journal subscription form in everyone's attendee packet. And we have the card reader. Thank you, Professor Batfield.
I'm happy to email your reading list if you email me that. Okay, because I give you.
I have a question.
Oh, go ahead.
So, I'm going to try to sneak two questions in. One is the Blue Cross Blue Shield representative. So the Mental Health Parity Act, are you all honoring that? I mean, as far as,
So are you really asking me, do we comply with the law in a legal symposium? I mean,
you better believe it. You better believe it.
so the answer to that is going to be yes. We have a full legal team and outside counsel as well, so yes.
Okay. And then the other question, well, because, okay. The other question is for Dr., is it El-Sabawi?
Sabawi. Not a doctor yet. I'm a JD. You know they don't like us to be.
Yeah, so I'm curious, so what is I've heard what you're kind of against. What is your proposed solution? That's what I would like to hear.
My proposed solution would be in the governing addiction book. I hate to refer to it again, but they, like I said, have looked at all the measures. For health policy, we do a lot of comparative studies because I study systems, but we don't do it in drug policy, and I don't know why. They do that in that book, and they look at all measures. It's a little dated, about 2014 maybe, but not that dated. So I would recommend looking at that. So it's what they call a public health approach, which does focus, it decriminalizes for the user, but focuses on stopping supply from coming into the more interdiction, supply coming in, and taking, redefining it so it's problem drug use and making services free and available, having wraparound services. It's pretty in-depth. Like it's much more of a wraparound, more holistic definition of solutions. So I would take a look at it.
In the front row.
I'm voting for Michelle here in the front. She's been very patient in her view. And
I think I need the microphone. I had a question for the physicians, but it appears they've left the room.
Yes.
Yes, I'm sorry, they had to leave.
Okay. Ms. Winton from Blue Cross. Since Blue Cross has instituted the requirement for the pre-authorization, has Blue Cross done any analytics about the effects of that? Do we know numbers that were denied as a result of that requirement? The load for opioid load for the enrollees? Do we have that kind of analytics?
Yes, we do have a lot of analytics on it. One of the things that I can tell you is that we saw a 6% reduction in long-acting opioid, which is what we have the prior authorization on. But we saw a complete uptick in short-acting opioids because we don't have a prior authorization on that. So it's no good deed goes unpunished. But we have seen a significant decrease in the number of claims that have come across as a result of people requesting that type of information. And we also saw it allowed us to have dialogue with the physicians to see, okay, here's some of the things that we need from you from the outset, which allowed us to make better policies in terms of what the prior authorization is asking for. So yes, we continue to look at that data.
Quick question. Blue Cross Blue Shield. Ben, I'm from Lakeside. I'm wondering, I've had patients come in, heroin addicts, and we are not able to get them certed through insurance because they are not detoxing. And we have had to literally let patients wait in our hallway for, the guy just said it earlier, for an extended length of time, and most of them don't make it. They walk out, and we cannot commit someone for drug addiction. So has there been any talk on trying to a little bit more compassion in that area, just because I'm losing too many friends.
So if you could, I honestly don't know that issue, and that's not something that we even get complaints or inquiries about. This is the first time that I'm hearing that. So if you could let me have that information or send me some.
Yeah, we'll email back.
Yes, that'd be perfect. Thank you.
Thank you.
Hi, my name is Kaylee Thacker. I'm a proud Memphis Law alum. Thank you all so much for being here. I'm beaming with pride today. So I know that we're talking about the opioid crisis today, and it seems like most everyone has talked about it from an abstinence-only perspective, and I'm wondering if any of you have considered harm reduction models and how that might be beneficial to lessening the number of people and lives who are lost on an annual basis in America to this issue.
So I think we flew over a lot of stuff here today. So a couple of the panels talked about medication-assisted treatment or therapy using buprenorphine, using methadone, and the way that works best is when it is highly personalized to the patient. And for some patients, there is a goal of abstinence, of getting to abstinence, and for some patients, there is not. And sometimes it is a maintenance therapy. at some level for a long period of time, and sometimes it's for some period of time, and then you have to make a shift with that patient. So I think that there is a lot of thought in that regard about harm reduction. I will say the thing we didn't talk about today, for which there is truly no good evidence, is the use of marijuana as a harm reduction, and that is certainly in the public conversation. But having reviewed very carefully the scientific evidence, there is not good evidence for that as a solution at this time.
There sure is a good narrative.
I actually talk about that in my paper. Yes, I do. But I was just going to say it's the public health approach. When drug policy people say that, they mean harm reduction. So that's the book, the Governing Addictions book. The European approach by the two top nations that have the best outcomes use a harm reduction approach. I'm not saying they have injection rooms necessarily. Our view as Americans of what harm reduction is and the European view of harm reduction is very different. Their view of harm reduction is that we're not going to legalize it, okay? What we're going to do is look at all the social determinants of the problem, and we're trying to reduce the harms around the drug user. So we don't want our addicts to be homeless. Let's get them housing. We want to make sure they have some type of insurance to help pay for the services. Let's teach them job skills so they can work and have a purpose. That is what the harm reduction idea in drug policy is very different from the narratives we're using about let's legalize it or let's have injection rooms.
Safe
I would only
injection exchange.
I would encourage you to go to Colorado and see it firsthand.
I'm not saying marijuana is good.
I would encourage you to go see it firsthand. And I would also say about the MAT, and listen, law enforcement, it's been a struggle for us to also, and we were embracing, but there's I don't think we need, my personal opinion is jumping into another replacement drug, because we are seeing a lot. And we also have to remind ourselves, guys, on our toxicology and our forensics examples and things where we indicated that heroin is going up, fentanyl is going up, buprenorphine's going up, and buprenorphine going up as mentioned in those overdose deaths. It's also going up. Now, I'm not saying you're naturally going to see that when you're seeing more and more of it being used. There's going to be a natural diversion of it, and that's okay. I'd rather see that than the heroin, but we still have to remember that's a very addictive and powerful drug in itself.
I'd like to clarify something from, overseeing an addiction medicine residency program. The replacement therapies, they're not considered to give a high. They're not classified as, the same drug. And one of the things we care deeply about is like a person can function as opposed to their skin's crawling with the cravings. If a person gets a drug that allows them to participate in their life and show up for work and show up for their relationships, we care about that. And so the methadone maintenance, yes, you have to go, it's a daily commitment, but if you're showing up for your life in other areas where you would be crawling out of your skin, I think it's a better alternative. An expensive one, but it's a better one.
What's our street value for methadone?
I think that's another symposium.
I think there's a kind of a misunderstanding a little bit going. Maybe we miscommunicated from the public health angle. So I want to just clarify it. The role of public health, we agree that there should be some supply reduction. However, we want to know why people are using drugs. Why does somebody take a drug? To alter their consciousness. Why are people trying to alter their consciousness? So the harm reduction or the true public health approach says, are these people depressed? Do they lack hope? Do they need job retraining? What do they need so that even if they successfully finish a program, they're not tempted to reuse again because their environment hasn't changed? So, let me know if you think I'm misquoting kind of the public health perspective, but that's...
Yeah.
That's what we think. So
that's true primary prevention. I think the reality is that if we look at public health practice, it crosses the entire spectrum of that care.
Yeah.
So
There's been a significant, demonization in some regard of industry today. But I have to say that industry is also trying to make products that will provide these treatments and allow people to get their lives back and be productive parents and workers that also would not be divertible. So injections, for example, and implants. And so that could solve the problem that law enforcement has and give people time then to focus on their psychosocial recovery.
Yeah. I do think we had two more questions, and it is 4:30 that have been waiting.
I just have a quick question. Thank you. Have you noticed any overlap between drug users and low-level drug dealers? And for individuals that might fall into both categories, is the solution that you all propose treatment programs, or would it be incarceration?
There's no question there is overlap there. There's no doubt. And each situation is going to be a little bit different assessment. I mean, by all means, if we can get to them early, it's going to be small amounts, low-level amounts, then absolutely. We do encourage treatment. We want to get to that person early on before it elevates to a point. Because anybody, there's a rule of thumb is if you can afford to do the dope, you can't do the dope that you can afford. Most people can't afford it, so the way that they have to resort to crime or criminal activity to feed their addiction. So obviously, we would much rather divert them in the beginning. But down the road, if that unfortunately results in a death of someone else, or their crimes elevate to a point, then we have no problem prosecuting that person.
And the last question, yes.
I think John Dolan, criminal defense lawyer, Memphis and Mississippi for now approaching 40 years. I'll take away from this today that there are a lot more facets to this problem than even I thought about. And Dr. El-Sabawi a moment ago almost summarized what's going on. I spoke with one of the presenters earlier, and my question is almost more philosophical. Will we as a society get to a point where, from an economic premise, we simply have to allow the maladaptive behaviors to have its natural and normal consequences? Will we have to allow these addicts to die so that we can stop sending them into the emergency room? And I'm sorry the physicians are not still here. Time after time after time again, and stop utilizing our resources to treat these people who won't behaviorally or cannot behaviorally comprehend and adapt to something that will fit into our societal norms.
You get a hard no from me.
Sir?
Go ahead,
Just a hard no.
A hard no that we should never get there?
Well, if you're talking economically, our division's run by economists, and I'll tell you right now what they would tell you is loss of life costs money, and that the cost of loss of life, even if it's just a death on the community, is an economical cost that you have to factor into that question.
I think the physicians would definitely say no to that, despite the use of resources, just from my conversations with them. And I would pose a question, is that really the world that we want to create?
Exactly. All of us love life.
Yeah. Alrighty, on that note, I am going to wrap up our day here. Before we all leave, I do have a couple quick announcements and a couple thank yous to do, so give me 2 more minutes of your time. First, this day would not be made possible without the speakers that are here at the front that have given time, effort. Not only have they given of their time to be here right now, but of their time to synthesize this material and present it to you in author manuscripts that we will publish in our journal. We're incredibly grateful. Also, our sponsors, for those that are still remaining, this day would not be possible, and all this continuing education credit, CLE, CME, CPH, would not be made free to everyone without them, including Lakeside Behavioral Health System, Bank Tennessee, Lewis Thomason, Association for Women Attorneys, Butler Snow, and finally, the Frager Law Firm. So we're incredibly thankful for our sponsors. And finally, behind the scenes that has run incredibly smoothly today, the Law Review has put in a ton amount of work into this event and has made it possible and made it run seamless for all of you today. So we're incredibly grateful for them, although they're not in the room. They're waiting for you out in the reception, which is my final remark. There were many questions left unanswered, so we invite you to our reception, which is just in the atrium right here, to join us. There will be light refreshments and a few beverages for you. So thank you for attending and for all of your time today as the attendees to engage in this important discussion. So thank you.
If I could pray upon your attention for just 30 more seconds, Managing Editor Connor Dugash and I would like to present Rachel with a very small token of our appreciation for her dedication and hard work over the last year. This really could not have been possible without Rachel, so please join us in thanking her.